Hello, my name is Dr. Andrew Gergis, and I'm going to give a brief presentation about insulinoma as part of my master's assignment. So to start with, um, we'll discuss some few facts about insulinoma. So insulinoma is a functional neuroendocrine tumor which secretes insulin, and it is the most common cause of hypoglycemia that's related to endogenous hyperinsulinism. Um, so it can be just a solitary tumor, or it can come as part of Min-1 syndrome, um, and it causes episodes of hypoglycemia, and it presents itself mostly as fasting hypoglycemia. Um, More commonly, it's benign, but it can also be malignant in few cases, which is about 5.8% of the cases. The etiology of insulinoma is not yet fully understood. We understand that there is a strong correlation between um, Min-1 syndrome associated insulinoma and a mutation in 11q13 chromosome in Min-1 gene. We understand the correlation between the high insulin and the hypoglycemia, that the high insulin initiates glycogen synthesis and it suppresses both glycogenolysis and gluconeogenesis, and all of the three can lead to hypoglycemia. So the clinical features are associated with hypoglycemia. Insulinoma is most likely to be associated with fasting hypoglycemia, but some patients would have both fasting and postprandial hypoglycemia. Very few patients, and mostly men, would be associated with only postprandial symptoms. Symptoms of hypoglycemia can be sympathoadrenal or neuroglycopenic symptoms or both. So sympathoadrenal symptoms can include palpitations, tremors, and sweating, while neuroglycopenic symptoms can include um, change in behavior, blurring of vision, confusion, and seizures, and is very much associated with severe hypoglycemia. Forgetting the hypoglycemic episode can happen, and rarely insulinoma can present itself with mental health symptoms. To confirm hypoglycemia, the patient should have Whipple's triad, which include hypoglycemic symptoms, biochemical evidence of hypoglycemia, and improvement of symptoms post-correction. So diagnosis include both biochemical test and localizing of the tumor. The gold standard biochemical test is a 72 hours fasting test, which should show low blood glucose, high C-peptide insulin and proinsulin, and negative sulfonylurea in urine or plasma. Non-invasive imaging includes CT with contrast, which can detect about 70 to 80% of the insulinomas. Pancreas-focused ultrasound is an option, which is a cheaper option as well. MRI can detect about 85% of the insulinomas, and there is also some studies which are promising in GLP-1 imaging. This is a CT of insulinoma, and this is an MRI for insulinoma. So if non-invasive investigations are inconclusive and there is still high suspicion of insulinoma, invasive investigation should be done. And they include the endoscopic ultrasound, which is much better than the CT and can detect up to 95% of the insulinomas. And the other one is a selective arterial calcium stimulation test with hepatic venous sampling. And it's also very sensitive and can detect up to 93% of the insulinomas. And this is an endoscopic ultrasound of insulinoma. Malignant metastatic tumors will have fasting hypoglycemia in less than 8 hours and will have significant biochemical features with very high insulin and C-peptide levels. It's very important to consider Min-1 syndrome in patients who have multiple endocrine pathologies or have family history of them. And it's very important to do genetic testing to all young patients who present with insulinoma to test for Min-1 syndrome. So moving to management, surgical resection of the tumor is the first line of treatment in local disease and is curable in cases of solitary insulinoma. This can be done by different surgical ways. Robotic resection of insulinoma was reported with good outcomes. In men 1, different surgical approaches should be done, like subtotal pancreatectomy with enucleation of the tumors. Endoscopic ultrasound guided ablation was reported to be successful in poor candidates to surgical procedures. Medical management should be tried while waiting the surgery or in poor surgical candidates. Other ways like lifestyle modifications, diet changes, glucagon pen, and steroids should also be considered. Cytotoxic treatment can be part of a palliative treatment, and PRRT can also be an option in inoperable cases. This is a diagram of management of benign and malignant insulinomas. Finally, we will talk about prognosis and recurrence. In successful surgical resection, the 10-year survival rate is about 88%. About 87.5% of the patients get completely cured. While in malignant insulinomas, a study has reported a 10-year survival rate of about 29%. Recurrence can happen. Its rate in insulinomas that are associated with MIN1 syndrome is about 21% at 10 and 20 years. The recurrence in insulinomas that are not associated with MIN1 syndrome is about 5% at 10 years and 7% at 20 years. And these are the references. Thank you.